All right, team. Welcome to the mission briefing. Today, we're diving deep into one of the highest stakes battlegrounds in medicine, cirrhosis and its complications. This isn't just a lecture. This is a tactical deep dive into mastering what we call the portal storm.
So let's get one thing straight. Cirrhosis? It's not just some liver problem. Oh no, it's a full-blown vascular disaster. Picture this. The liver, which should be soft and spongy, turns into a wall of stone. Just scar tissue. So what happens? All that blood trying to get through, it hits a dead end. And that creates this massive, catastrophic pressure backup in the portal system. We call that the portal storm. And knowing how to survive it is everything.
Now, in this storm, you need a compass. And your master compass is this number right here, 1.1. This single value is what will tell you exactly where that fluid backup in the belly is coming from. It's the key to your entire diagnostic strategy.
And here's your second critical number, 250. This is your alarm, your red alert. It's the threshold for a deadly complication, an infection we call Spontaneous Bacterial Peritonitis, or SBP. When you see this number, you know the clock is ticking, and it is ticking fast.
So that's the mission in a nutshell. We master that pressure gradient, and we disarm the infection trap. You get this right, you save a life. You get it wrong, well, let's not go there. Let's go.
Okay, a quick but a very important pause. Everything we're covering here is for your educational journey, for your exams like the USMLE, PLAB, or TUS. It is absolutely not medical advice. For any real-world clinical decisions, you must consult official guidelines and a specialist, always.
All right, first things first. We've got to navigate all that fluid. We're going to use what I call the SAAG compass. That stands for Serum-Ascites Albumin Gradient. It's a simple bit of math, but it's incredibly powerful. It tells us exactly which direction to go.
So let's paint a picture. A patient comes in, their abdomen is just full of fluid, massive ascites. An eager intern immediately starts ordering markers for things like ovarian cancer. Now, is that wrong? Not necessarily. But is it the most logical first step? Heck no. There's a much smarter, faster way to figure this out. And here it is. The math is beautifully simple. You take the albumin level from the blood, the serum, and you subtract the albumin level from that fluid in the belly, the ascites. So if your serum albumin is 3.5 and the fluid albumin is 1.5, your SAAG is 2.0. Simple as that.
And what does that number mean? Well, here's the golden rule. If your SAAG is 1.1 or higher, you are looking at portal hypertension. Boom! The problem is pressure. This immediately tells you that things like cancer or TB are way, way down on your list of possibilities. Those almost always have a low SAAG.
Okay, so you know it's portal hypertension, but is it the liver or the heart? Well, we have another simple test for that. We look at the total protein in the ascitic fluid. If it's low, less than 2.5, that means the liver is so sick it can't even make protein anymore. That's cirrhosis. If the protein is high, the liver is probably fine, just congested, and the real problem is coming from a failing heart. All right, let's shift gears to our next critical threat, Spontaneous Bacterial Peritonitis, SBP. This is not a drill, it's a race against time. And there's a very common, very deadly trap that people fall into.
And here is that trap. Your patient with cirrhosis has a fever. You tap the fluid, and someone, maybe a junior doctor, says, let's just wait for the culture to come back before we start antibiotics. You know what? That might just be one of the most dangerous sentences you can hear in a hospital.
Because when it comes to pulling the trigger on SVB treatment, there's only one number that matters, not the culture, not even the total white cell count. It is the absolute neutrophil count in that acidic fluid. That is your decision point.
So here it is, the one rule you absolutely cannot forget for your exams, for real life, for everything. If those neutrophils hit 250 or higher, you start antibiotics. Now. I mean, right now. You don't wait for rounds, you definitely don't wait for culture, you act. Immediately.
I'm not being dramatic here. This is the brutal truth. The cultures from acidic fluid, they're often negative, even when a lethal infection is burning through the patient. So let me say it again. If you wait for a culture, you're waiting for a funeral. It's that serious.
So let's lock in the protocol. Trigger, 250 neutrophils. Action, start cefotaxime or a similar antibiotic immediately. But don't forget the third absolutely critical step. The kidney shield. You have to give these patients IV albumin. This protects their kidneys from shutting down, which is a devastating complication called hepatorenal syndrome.
Okay, let's run a quick simulation. We're going to do some rapid-fire questions to encode this logic deep into your brain. This is the Cirrhosis logic matrix.
Let's go. SAAG is greater than or equal to 1.1, portal hypertension. Think liver or heart. SAAG is less than 1.1, no portal hypertension. Think cancer, TB, or pancreas.
Next, you've got a high SAAG. You check the protein, it's low, under 2.5. That's your liver screaming for help. It's cirrhosis. Protein is high, over 2.5. That's a congested system. Think heart failure.
2 more. What's the SBP treatment trigger? Neutrophils greater than or equal to 250. And while we're at it, what's the first-line treatment for that other huge complication, encephalopathy, lactulose plus rifaximin?
And there you have it. That's the core decision-making framework. It's a clear, logical pathway that will guide you right through the storm. Logic. Sealed. All right, that brings us to the end of our briefing. Let's do a quick debrief, confirm our objectives, and set our sights on the next target.
Mission accomplished. We've secured the parameters for diagnosing and managing the major complications of cirrhosis. The portal storms are complex, but now you have the tools to navigate them with confidence.
But the training doesn't stop here. Your next target is in Series G3.3, the biliary and autoimmune war. We're going to tackle how to distinguish PBC from PSC, how to interpret that classic beating sign on imaging, and master the complexities of prehepatic jaundice. I'll see you there. Mission dismissed.